Hi, I'm Dr. Neha Gupta, and I'm going to discuss regarding prolonged fever in people living with HIV. Prolonged fever can lurk in silently for long and then strike fiercely. It can be life-threatening. And I'm going to present this 37-year-old gentleman who in January 2025 presented to us with fever for more than 3 weeks. The fever was acute onset, was ranging between 102 and 104. He had multiple hospital visits with no response with antibiotics or with antipyretic medications, also associated with abdominal pain and vomiting. He was already on anti-TB drugs as well as on ART. The TDF 3TC DTG based regime was started in 2024. He was not on TMP-SMX prophylaxis. Blood test revealed mild leukopenia and a normal platelet count. ESR was markedly elevated. LFT showed increase in bilirubin, mild increase in the SGOT, SGPT, but a marked increase in the alkaline phosphatase. The creat was around 1. A month back, the CD4 count was done, which was around 146. The chest CT did not reveal any significant lung infiltrates, but the CT scan abdomen showed hepatomegaly along with splenomegaly. Now, for arriving at the diagnosis, which is the immediate, best, quick, and cost-effective solution in this patient who is having prolonged fever. Should we do blood cultures, urine for histoplasma antigen, PET-CT with contrast, liver biopsy, which could be sent for expert MTB, cultures, TB midget, fungal, histopathology, and fungal stains? None of the above. So the answer is that is the most quick and the cost-effective solution is to perform a good history. It's the art of history taking, and infectious diseases specialists are armed with this particular skill. So we went back and inquired. That history revealed that since September he had fever, which was diagnosed with typhoid, and then during this evaluation he himself thought that it could be TB because of his very strong family history of father and grandmother having tuberculosis. The TB tests were done, which were negative, and it is during this that he was diagnosed with HIV. And with diagnosis, he was really scared, and because of fear, he started the ART immediately before anti-TB drugs could be started. Subsequently, after ART, the fever and the cough increased. The CT scan, which was done later, showed that there were centrilobular nodules, although the microbiology was negative, but the patient was started on anti-TB drugs based on the history and the radiological findings. And this was 20 days after the antiretroviral therapy. So the fever and the cough resolved. But later in January, the fever started again, which was very high with abdominal pain, but this time there were no lung symptoms which were seen. Now, the next step is comparison of the various radiological reports as well as the blood reports, and we compared the radiology, which revealed that the centrilobular nodules, which were seen in October, had completely resolved. But this time, the CT scan is showing a new onset hepatosplenomegaly. So, with this history that the ART was started earlier, before the anti-TB drugs, and resolution of the previous symptoms and appearance of new symptoms, paradoxical response was the most likely diagnosis of first differential. So, is there any particular test which we can offer to the patient which can also support our clinical diagnosis? So, we perform this point of care test which can tell us regarding the CRP and the HSCRP in just 3 minutes, and the results showed that CRP is 41. Now, this patient who's having relentless high fever for 3 weeks with a CRP of just 41 indicates that it is less likely to be a bacterial sepsis and more likely to be an inflammation or a low-grade pathogen. So in this patient, based on the history and of course with this support from the POCT, no antibiotics were initiated. Ceftriaxone, meropenem, teicoplanin were not initiated, and also PET-CT was not done upfront. So as already we have the radiology reports as well, and the cost which was kind of saved was close to 40 to 50K in Gurugram. So here, now the next step is how do we manage this patient? So this is a patient who is already on ART and anti-TB drugs. Should we continue both and then perform the liver biopsy to rule out opportunistic infections and other etiologies, and then start steroids as this is the likely diagnosis? So, or stop ART, continue AKT, perform liver biopsy, start steroids, stop ART and AKT both, perform liver biopsy, and initiate steroids, or none of them were. So what we did was, as paradoxical response was likely, we stopped the ART, continued anti-TB drugs, performed liver biopsy, and started on the steroids. So when we talk about management and treatment of virus, it is mentioned that clinicians should not interrupt antiretroviral therapy except in case of severe life-threatening virus. But here, this is a patient who has severe granulomatous tuberculosis, which can be life-threatening if it is left untreated. So the ART was, and the treatment is individualized, so the ART was stopped. This patient was admitted, liver biopsy was performed, and then he was initiated on prednisolone, which is steroid, and the next day the fever resolved. But on the anti-TB drugs, as we can see, the LFT kept on worsening. So first-line anti-TB drugs, because of the suspicion of DILI, were stopped and the modified anti-TB drugs were initiated. With this, there was a gradual decline in the bilirubin as well as in the LFTs. Meanwhile, we have the reports. The CD4 is 210 and the viral load is, he's not having virological failure. The liver biopsy did not detect tuberculosis or any opportunistic pathogen. The gastro reference was also done. The other etiologies of viral hepatitis were excluded. Now, histopathology did not show any fungal stains positive, but it showed that there is epithelioid granuloma, as well as there are these eosinophils with spotty necrosis, which is suggestive of drug-induced liver injury. So this patient has paradoxical response with a drug-induced liver injury. So the basic approach in a patient who is present with prolonged fever and is on anti-TB drugs and ART should include that, whether it's TB or not TB, whether it's drug-resistant tuberculosis, could it be paradoxical response, could it be inadequate drug TB levels, and we should always rule out virological failure or failure. So coming to the recommendations regarding the timing of ART in pulmonary TB patients, CD4 count, if it is less than 50, then the recommendation is that the ART should be started early, but that is always associated with the risk of iris, and hence prednisolone is recommended, but that is just B1 recommendation, and again the timing or the initiation of prednisolone needs to be individualized, taking into account the risk of OIs, hypertension or hyperglycemia associated with the prednisolone. And in patients with extrapulmonary TB, it's better to delay the therapy and start ART probably 4 to 6 weeks later. So the ART timing has to be individualized based on the site of TB as well as on the CD4 count. So on follow-up, this patient is doing well on the modified AKT. On tapering steroids, the ART was reinitiated. He's done well. The SGOT, SGPT is almost within normal limits, and that's why rifampicin has been reinitiated again. To summarize, this case highlights granulomatous hepatitis as a paradoxical response. Steroids can be life-saving, especially in severe iris. Again, this case emphasizes the importance of appropriate history taking, which can impact an early diagnosis, early recovery, and can be very cost-effective. So I would like to summarize with this quote from Sir William Osler that we must always listen to our patients because they are telling us the diagnosis. And with this, we welcome you all to SITSCON 2025 as well. Thank you so much.